Good morning, everybody. I'm Pete Harckham. I represent the 40th Senate District, which is northern Westchester, parts of Putnam, parts of Dutchess County, so it's the lower Hudson Valley. Here this morning with the New York State Association of Counties to talk about the Medicaid proposals in the executive budget. Just as a little background for folks who don't know, New York is a unique state, one of the very few states that has a local share of Medicaid. In most states, it's 50% federal, 50% state. Here in New York, it's 25% local, which comes through the county portion of the property tax, then state 25%, and then 50% federal. Years ago, because costs were rising so rapidly, local property taxes on the county side of the ledger of the property tax were rising so quickly that the state began to cap the growth of Medicaid spending because the state just couldn't afford to assume the entire cost. So then several years later, in return for the property tax cap of 2%, the state agreed to cap Medicaid costs. So for instance, in Westchester, about 40% of the county share of property tax goes to fund Medicaid. That was capped years ago. So the proposals in the executive budget to begin to claw back money from the counties is alarming to the counties and should be alarming to the taxpayers because this will go directly to the property tax. The other thing is this will hit all counties from New York City, Long Island, the Hudson Valley, and the northern parts of the state. So this is not one of those deals where only the city gets hit or only upstate gets hit. Everybody gets hit, and there's several components to this. I'll introduce Stephen Acquario in a moment, who's going to take us through this presentation. But the statewide total could be over $800 million annually. You're looking at FMAP clawbacks of $700 million, and on the penalty side would be over $115 million if they fail to stay within the cost cap. The other thing that's very challenging about this is that the counties are going to be required to control the cost of Medicaid growth, and yet they don't actually manage the Medicaid program. So they're really in between a rock and a hard place. And so we're looking at an $815 million clawback annually, essentially, from the counties, which is a big hit to property taxpayers. Certainly on the radar of everyone in the Senate and the Assembly, the challenge is going to be what are we able to do about that. So with that, I want to turn the presentation over to someone I first started working with when I was a county legislator in Westchester, became a member of NYSAC, worked closely with this team. Steve will introduce his team. There are several NYSAC team members here. But with that, I'd like to turn it over to Stephen Acquario, who's the executive director of NYSAC, which represents the interests of all the counties, big counties, small counties, urban counties, rural counties, and they are the voice of the counties in New York State. So with that, Steve.
Thank you, Senator Harckham. I appreciate the opportunity that you brought us today to convene a forum for your peers, for members of the state legislature, in particular the state Senate, to understand the Medicaid proposal that's under consideration right now in the executive budget. And I thank you, Senator, for caring about your property taxpayers, for caring about the people in need of quality health care in Westchester County and in your district in Dutchess County and Putnam County. You're someone who truly cares about the people in those counties and the taxpayers in those counties, and your efforts here today demonstrate that. So thank you very, very much for talking about Medicaid. A lot of fears today, last week, last couple of months with the coronavirus has been widely reported by our governor and the work that the state of New York is doing. But so too are the counties working every day, every minute, every hour on addressing the public health needs in our communities. The county public health departments are the lead agency who are responsible. The primary barrier in public health, protecting people's health, and we'll continue to do that, working with the state of New York. But that's just one example of how county governments are interacting with the people and protecting the people and protecting the people's health. We're going to be responsible for quarantine type issues, for isolation incidents, for educating the public, making sure that people have the care that they need in their home or in their isolation or wherever they are. Counties are going to be that entity responsible for making sure that the people are taken care of and have what they need to be safe while under isolation or quarantine. So it's just an example of how local governments need to use and apply local resources first and need state assistance to supplement that. The present Medicaid proposal that's advanced takes that into a whole higher, different level. And will we have those resources that we need to address local concerns as well as deliver state services? That's really a question here. So while coronavirus, we need to pay attention to facts, what is factually out there, as the governor has talked about, the president has talked about, and not necessarily fears. Here with this Medicaid proposal, we are fearful. We are fearful for our taxpayers. We are fearful for other programs and services, for the elderly, for the youth, for Meals on Wheels, for fixing potholes, for improving public safety, 911 system upgrades, to care for our veterans. How will all these programs, which are predominantly done at the local level, be accomplished if we are in fact asked to use local resources to pay for what is a federal state program? The counties of New York should never have been in the Medicaid program. Since its inception in 1966, no other state in the United States does run a Medicaid program with local taxpayers funding $7 billion. In fact, the New York counties, we pay more in this state at the local government level than the 3,000 counties around the state. We pay as much as 40 state Medicaid contributions in local government in New York State. So the Medicaid proposals that were advanced by Governor Pataki, they should be kept. Governor Pataki was right in 2005 when he controlled the growth of Medicaid spending. Why? It was growing in double digits in the 2000s. Why? Because the state expanded the program. And so what happened when Governor Cuomo came into office? That trajectory was still going up 3%. Our property taxes were still too high. And Governor Cuomo championed the property tax cap, a hard freeze. Why? It was the right thing to do. He knew it then, and he knows it now. Our property taxes are too high in this state. So we are paying attention to facts. Those facts we want to present today to the state Senate, and we are presenting the fears. This is about facts. This is about fears. This is about the people of New York at the local community-based level and bringing that message to the State House here. Medicaid should be paid on the broadest tax base possible. The people of the United States and the people of the state of New York. The property taxpayers should not be funding a federal state health care program. So we have a presentation today. I'd like to call on David Lucas. We'll walk through about a 15-minute presentation. You can understand the three-pronged proposal that's on the desks of the state senators in Albany and the state assembly members. And we hope that after this 15-minute presentation, you'll have a better understanding about how this impacts local government. Dave Lucas.
So I'll just quickly go over this. Some of you have seen this in the governor's budget presentation, so we're just going to go over it quickly. Here on the first slide, We know the state is facing a big deficit in its Medicaid program right now. It's about $4 billion. So the governor has set up his Medicaid redesign team to find $2.5 billion in savings. The other savings he's identified in his budget is to tap counties in New York City for $150 million on an annual basis going forwards to pay more for Medicaid. We estimate on the low end the fiscal impact at $150 million as proposed in the governor's budget. But over time, this could easily grow to well over $1 billion because the budget provides the authority to the executive to claw back funds and to assess penalties going forward that are going to be harder and harder for counties to avoid. So we think the top end could be as high as $1.7 billion. That's not all on a recurring basis, but most of it would be a recurring hit to counties. Next, thank you. For our host county here, this is the range of cuts what we're seeing that we're estimating. It could be anywhere from $5.5 million up to $45 million on an annual basis the further down the road we get into this process. We encourage folks to go to our website. You can check any county in the state and what the impact might be on your county. It's NYSAC.org. Keep the calculator. Next. The Medicaid program is pretty complicated to begin with, so we're trying to simplify what's being proposed in the budget, and there's a lot of history behind some of these proposals. Some of them go back over a decade. The first major proposal is something the state is proposing to redirect what they call EFMAP or enhanced FMAP savings from counties and divert those to the state. Now, EFMAP is enhanced FMAP, and it goes back originally to the ARA provisions that occurred during the Great Recession when the federal government passed the giant stimulus bill to help get us through the Great Recession. Part of that was they increased the amount of money the federal government paid for Medicaid, so they increased their matching share. And in New York, because counties paid a share, the New York congressional delegation wrote into the law that counties would share in that benefit. As the feds paid more, some of that savings would fall down to the counties in addition to the state for the portion they paid. So when the Affordable Care Act was enacted in 2010 when it passed, these provisions from earlier were carried over, and again, the New York congressional delegation, it was their intent that these savings be passed directly to counties. And actually, since the beginning of the state's implementation of the Affordable Care Act, the state has been passing through these savings to counties. The budget would change that. The budget language would allow the governor to divert these savings, and as we indicated, it's a pretty big number. This chart here shows the annual savings is probably around $700 million right now. Which is a really big number for counties. You can see the $7.6 billion on this chart. That's the state statutory cap that was enacted into law by Governor Cuomo and the state legislature in 2012. We started that cap. The Affordable Care Act savings, the federal savings, are piled on top of that. And the way we've benefited as counties is the state has told us we can pay less for Medicaid and use the federal savings as part of our contribution to the matching rates. Next. And as I said, they pass through the savings to us. They pass through about 80% of the savings in any given year, and then at the end of the year, they usually reconcile the difference. They don't know exactly what the savings are going to be, so they pass through 80% to be safe. We agree with that 100%. We don't want to have counties in New York City writing big checks back to the state at the end of the year because they overestimated the savings. So they've been doing this right from the beginning, starting in 2012. They pass along 80% of the savings. The counties in New York City get the benefit, and then they reconcile. So the problem we've had in recent years is they've stopped reconciling these funds. We're 3 years behind in reconciliations, and each year about $100 million goes back to New York City and the counties through the reconciliation process. So we're 3 years in arrears on that. We think it could be up to worth $300 million or more. So we have the full annual impact we talked about of $700 million. We have $300 million in arrears today. That $300 million in arrears could grow by 2021 to almost $500 million. So we think up to $1.2 billion is at risk here just from the EFMAP proposal as time goes on. We don't expect the governor to take all this money back the first year, but he could take it back quickly if he needed to in a difficult budget situation for the state. Next. Okay. The next issue is it requires each county that operates under a property tax cap to stay under the cap. And if you don't stay under the cap, you would owe a penalty back to the state. And you would basically lose the incremental savings that would accrue to each county from the two caps, the 2005 cap and the 2012 cap. New York City, they would have to limit their property tax levy growth to 2% or lower. Otherwise, they would also be subject to the same penalty. This is a pretty big penalty. No counties went over the cap last year, but that's truly a function of, how strong is the economy? Have any new costs been shifted to the state, from the state to counties that we would have to absorb? And we are absorbing a lot of new costs right now from last year's budget. We got 30 days of early voting we're paying for this year with no state assistance. We're doing new lead monitoring in the counties, at least, that we're going to have to do. We think that is going to cost us up to $45 million. And there's some other items that we're also paying for this year. There's proposals in the budget that would take even more money away from us. For New York City, they think the 2% cap, if they go over that cap, and they think they would, based on history, would be almost up to $600 million annual impact or penalty the first year. And each time the counties go over the cap, if a county gets in a situation where they have to breach the cap because they can't afford or they can't cut enough services locally, that would permanently raise how much they contribute to the Medicaid program going forward. So that hit becomes recurring and cumulative over time. And it could create sort of a vicious cycle that you have recurring cuts in local services while the tax rates increase because you can't afford these penalties that are imposed. I mentioned the New York City impact already. Next. The third proposal, as the senator highlighted, was the idea that we have to control our local Medicaid cost growth to 3% or less. Anything above 3%, we would have to reimburse back to the state. The provisions of this proposal are not effective until the 2021-22 state fiscal year. This would allow time for the MRT proposals to coalesce and be implemented and hopefully would keep the cost down. But we do have concerns about this proposal. What we've done here is we've tried to rebuild what are the local Medicaid costs over time. So we had to kind of rebuild this using our own data and data that's been available from the state in some areas. And we've concluded that over the last 5 fiscal years, if you had this proposal been in place already, a typical county's average growth over the last 5 years was around 5%. So if we had to stay at a 3% cap and the average is at 5%, clearly there would be a lot of penalties assessed. And it's important to point out, during the last 5 years, MRT was in place, the first MRT. And it was designed to ensure Medicaid spending did not go over the cap. But clearly, in the years, even when they said they were controlling expenses, the local cost growth was still averaging 5%. So it's going to be very difficult for counties in the future to do that. And we've determined that each 1% we're over the target level, it costs counties in New York City about $115 million. And this is a map that kind of shows the cost per capita for these penalties. Another important factor here too is, in addition to the local cost growth we're expecting going forward in the state after MRT, the federal government also does these estimates, and over the next decade, they're assuming average Medicaid growth of about 6.2% in each state. So that's a pretty big factor and headwind we're facing in this situation right now. Again, the senator also highlighted this. We really have limited ability to control costs at the county level. A lot of the tools we used to have to do Medicaid audits have been centralized at the state level through the Office of Medicaid Inspector General. And just so many different inputs into healthcare where counties don't have a lot of control. And we'll just highlight some of those here. Something that's we need to know and realize as well is right now the state, as part of the 0% cap that was implemented in 2012, they also said they would take over all administrative functions from local governments, so for Medicaid enrollment and eligibility determination. They're partway through that process, but today they enroll 2 out of 3 Medicaid recipients across the state, outside New York City. And across all entities, it's around 60% that they're enrolling today. Under managed long-term care, services are determined by the state through a private contractor. That's not something we're involved with locally. The state sets reimbursement rates for healthcare providers, prescription drugs, durable medical equipment. These are often controlled by the marketplace or by the state, the pricing. Counties cannot control for demographic changes. We can't control for disability, aging, and the longevity of that population. Rates of illness, where we're seeing it now with this new virus on the market, in attacking the country, so to speak. Incidence, prevalence, mobility, or morbidity, those are all things outside of the control of the county and for the state, frankly, as well. Minimum wage increases, those are set by the state and driving a lot of new costs in the Medicaid program. The timing of payments and billings that are submitted by healthcare providers, these penalties would be assessed against counties on a cash basis. So whenever the bills are sent in and get paid, regardless of when that service may have accrued, that would determine how much your local share has grown or not grown. We also don't control the benefit design of the program or the eligibility thresholds. We determine if someone's eligible based on the regulations and rules we get from the state, but we don't set those thresholds. And again, to look forward to where we're going, as CMS and the federal government looks at what they project costs to be, they're looking at this kind of data as well, demographic data. Over the next decade, this is based on data from Cornell and some of their population projections, they're projecting that our elderly population, that's 65 plus in New York, is going to grow by 25% over the next decade, while the growth in the working age population is expected to decline by 3.6%. And this chart shows the breakdown between New York City and rest of state. Clearly, it's pretty predominant across the state that the elderly population is going to grow. Next. It sets up some issues we really need to watch closely. As the elderly population grows, they're going to have higher needs in the Medicaid program. Some of them will end up in Medicaid. Some of them will not end up in Medicaid. Those that don't end up in Medicaid are really going to come to the county for services. As Steve mentioned, we've got Meals on Wheels, other aging services that we do locally. Those service needs are going to expand. And as the working age population falls over that 10-year period, that means revenue growth for counties and the state is going to decline as well, or not grow fast enough to keep pace with the aging of the elderly population. So we're very concerned about this issue. And again, as Steve mentioned, we think the local Medicaid caps have worked well since they began in 2005. And here on the slide, we have the 3 reasons listed by Governor Pataki at the time of why the caps were necessary in 2005. First, to help control property tax increases due to state Medicaid expansions. This has worked enormously well. In the years leading up to 2005, the state did a very large Medicaid expansion that expanded eligibility. Enrollment increased by almost 50% between 2001 and 2005. So in those years leading up, the average property tax increase was about 7% per year. A lot of counties were double digits. In addition, over 35 counties increased their sales tax by an additional penny during this period to keep up with the costs. So it had a huge impact. Since that first cap went in place, the average property tax increase across all counties has been below the rate of inflation from 2006 to 2020. It worked as well as it was supposed to. Also, the state was wanted to be fully responsible for new Medicaid costs, and they wanted to vest responsibility for the program costs on the entity that controls the program, which is the state. Also, again, as Steve mentioned, the state tax base is much larger, more progressive than local taxes, and it's better suited for handling the financial burdens of Medicaid. And also, the cap has helped the state as well. We've looked at how the cost growth was for the state share spending. From 1997 to 2005, the state share spending was growing at over 7% per year. After that first cap was implemented, it has dropped to 3.6% a year. So we think overall these caps have worked as intended, and we need to maintain those going forward. And we want to make sure that the entity that has the most ability to control the program has the fiscal responsibility to do so, and that is the state at this point.
Any questions? A lot of policy in these proposals, but I want to thank Senator Harckham.
Question back there.
Please.
I just thought it might be helpful if you talked a little bit about county budgets and that timeline and how that interplays with the state budget, because it's not a one-to-one comparison.
Okay, so the counties are in a calendar fiscal year right now, as the city is, I believe, a June fiscal year. So the state is in an April fiscal year. So any shifts right now in state policy have a dramatic and immediate impact in county government operations. We're on a calendar fiscal year, and so that's why these policies really matter right now. We can't have cost shifts. Again, it would be quite severe to the local budgets if they are shifted in mid-year or in any year. We're not in a position that we don't, this is well beyond the capacity of a local government budget to assume the state and federal responsibility for the Medicaid program. And that pretty much sums it up. And our message is simple. To the state legislature and to our governor, the message is simple. Keep the cap. Stop the squeeze. Stop squeezing local taxpayers and keep the cap. They work. When the state has responsibility for its Medicaid program, it then logically creates a sustainable program. It works. We just showed you the charts. Those are the facts. That's the reality. Any other questions or comments? I want to thank everybody for coming today. We appreciate everything. Thank you, Senator Harckham, for having us.
Thank you, and thank you all for coming. Thanks.
Thank you.